Dear audience, let me introduce my PhD topic, which is psychological aspects of health promotion and disease prevention. Eating disorders are life-threatening psychiatric conditions which often remain untreated due to the patient's lack of awareness and compliance with the treatment. Patients with eating disorders usually experience gastrointestinal symptoms, but only 11% of them reported to receive treatment for their gastroenterological conditions. In this systematic review and meta-analysis, we found that the prevalence of functional gastrointestinal disorders in patients with eating disorders is 63%, which is 2-3 times more than in the general population, but there's no difference in organic gastrointestinal disease. Functional gastrointestinal disorders should routinely assessed in patients with eating disorders to enable comprehensive multidisciplinary care. Further research are needed to explore the bidirectional link between the two diseases. Policymakers should ensure that clinical guidelines recommend routine screening and gastroenterological evaluation when it's appropriate. My name is Zsófia Németh. I'm a psychologist. I'm working at the Institute of Pancreatic Diseases at Semmelweis University. My vision is an evidence-based healthcare system that bridges mental and physical health, promoting the well-being of individuals and communities. And my mission is to promote psychological research for better patient care and explore the potential of psychological interventions. To achieve my vision, I have 3 ongoing projects which I would like to present today. My first project is investigating the prevalence of gastrointestinal disease among patients with eating disorders. It will be a systematic review and meta-analysis. Eating disorders are psychiatric disorders with the highest mortality rate. In the general population, the prevalence of the disease is 8%, but in gastroenterological practice, it's higher. We know that there's a bidirectional relationship between the two disorders. And the problem is that patients with eating disorders usually receive late diagnosis, and because of them, 90% remain untreated, and up to half of the patients never achieve recovery. And our aim is to investigate the prevalence of gastrointestinal disease among patients with eating disorders. The clinical question is that what is the prevalence of GI disease in patients with eating disorders? Our hypothesis is that there is a high prevalence of GI disease among patients with different types of eating disorders. We conducted the systematic search in 3 big databases, and first we had more than 12,000 articles, but after the selection process, 120 articles stayed in our focus. I would like to show you this summary table. You can see that it divided into 2 parts. First of all, you can see the prevalence of functional gastrointestinal disease among anorexia nervosa, bulimia nervosa, avoidant restrictive food intake disorder, and eating disorder not otherwise specified. And in the second part of the summary table, you can see the prevalence of organic GI disease in different types of eating disorders. You can see that the functional disorders prevalence is higher than the organic ones. I would like to show you this forest plot. The importance of this is that functional gastrointestinal disorders are common gut-brain axis disorder causing gastrointestinal symptoms without any structural or biochemical abnormalities. In this forest plot, the unit is percentage. It can be between 0 and 100. It contains 13 studies and more than 1,000 anorexia nervosa patient data. The included studies are cross-sectional studies, and we can see that the prevalence of functional gastrointestinal disorders in anorexia nervosa is 63%. This is clinically significant, and this suggests that screening the patients for functional gastrointestinal disease is important, and it's also important to not only to screen, but to treat their disease. In this plot, we can see the prevalence of organic gastrointestinal disorders in anorexia nervosa. The unit is percentage. It can be between 0 and 100. It contains almost 20,000 anorexia nervosa patient data. The study is also cross-sectional ones, and we can see that the heterogeneity is quite high. It's because of the the examined population. It can be because of the gender, age, and different diagnostical methods for the eating disorders and for the gastrointestinal disease as well. We can see that the prevalence of organic disease is 9%, which is clinically relevant, and this suggests that screening eating disorder patient for gastric disease is not that essential, because the prevalence in normal population is the same as in the population of eating disorder patients. Now I'm on the manuscript writing phase of the work, and I hope to finish it in a week. My second project is investigating the effect of social support on lifestyle risk factors and chronic disease among European citizens. It will be a Eurostat analysis. We know that the prevalence of chronic disease is very high, and usually lifestyle risk factors are hiding in the background of the disease. We also know that changing these lifestyle risk factors are not that easy. And our aim is to investigate the role of social support in lifestyle risk factors and chronic disease. And our hypothesis is that social support is associated with lower prevalence of lifestyle risk factors and chronic disease. And if our hypothesis is true, we can involve family members, peers, and we can create different therapy groups for patients who are suffering from chronic conditions. I prepared the research proposal, and I also requested the data from the Eurostat community. So now we are waiting for the data, and after we will start analyzing them. My third project is investigating diabetes preventive lifestyle interventions after pancreatitis. Acute pancreatitis goes with high mortality rate, and the incidence of the disease is growing. We know that there's a connection between acute pancreatitis and diabetes, because up to 40% of the patients after acute pancreatitis develop post-pancreatic diabetes mellitus, which is connected to higher severity and higher mortality rates in acute pancreatitis. And the problem is that patients after acute pancreatitis are high-risk population for diabetes, but this knowledge is not in the guidelines. There's a gap, and because of that, our aim is to determine the best lifestyle intervention to prevent diabetes after acute pancreatitis, and we would like to create a protocol and guideline for this issue. We have two clinical questions. First of all, that complex lifestyle intervention can be an effective way of preventing diabetes after acute pancreatitis. And the second question is that what kind of resources should we use for this kind of interventions. It will be a randomized control trial protocol, and our hypothesis is that complex lifestyle intervention will be the most effective way of preventing diabetes. We will create 4 different groups. The first group would receive the intervention from different experts of the field, doctor, dietitian, psychotherapist, and psychologist as well. The second group would receive one person intervention from one expert of the field. The third group would receive just an information booklet about the information, how they can prevent diabetes. And the third group would receive the standard care, the discharge informations. And as primary outcome, we will check the development of diabetes mellitus with the level of hemoglobin A1C, fasting glucose, fasting plasma glucose, oral glucose tolerance test, and if the patient received diabetes treatment or not. So I have this 3 ongoing project now, and I would like to close my presentation with the World Mental Health Day slogan. Remember, it's okay not to be okay. You can heal your mind and shine your light. Thank you for your attention.
I have a question for the third project. How do you imagine these interventions? Is it a one-time intervention or repeated interventions compared to each other?
First of all, we have to sit down with my colleagues from the expert of every discipline, like dietitian, physiotherapist, and doctors as well. And we have to check the gold standard recommendation for diabetes prevention. And after we can work on this protocol together. But I think it won't be just a one-time intervention. I think we will create it that we will call back the patient regularly and give them the intervention quite often to reach our goal.
Zsófia, we are working together in the Institute of Pancreatic Diseases, and yearly we have around or more than 1,000 patients. My question is probably how many of these patients has eating disorders? What is your opinion? Because this, a lot of, when you go back this slide, when you have a subgroups type of eating disorders, is a lot of. Yes, yes. And it is good when we have a diagnosis for the eating disorders. It is super, but my question is, what is your experience, or what is your vision? How many of these patients, or you have a screening for this? How to make a focus for these patients?
We not yet have this screening process for eating disorder in our hospital, but we try to be aware for this. And during the past year, we had to recommend the patients to go to and find a psychiatrist for this kind of conditions. So we have found some patients. It's not that common. And in this systematic review and meta-analysis, we found that the functional GI disease are higher than the organic ones. So I haven't found any study which examined the connection between pancreatitis and eating disorders and this bidirectional connection. So it's there. It's very rare, I think, in our hospital, but the subclinical form of eating disorder, which can be, for example, overeating, is very common. And we can see that obesity also. So in that cases, we have to think about not just the tradition, the lack of information, what the people are consuming and how many calories and what kind of food they are choosing. We have to be aware that maybe it's a kind of binge eating episode, emotional eating.
Yeah. In my clinical experience, they are less likely to have an eating disorder with pancreatitis. They are more likely to have drinking problems, however. This is just a comment.
Yeah, it's really common. The binge, not the binge eating, but the binge drinking episodes are really common in our world as well.